Welcome everyone to today's Innovative Discovery Series session. Just a note for CME credits, you must sign in and please include your email and credentials on the sign-in sheet, which is located in the back. And don't forget about our March 1st Tech Talk, which will be featuring Momita Bhattacharya from University of Delaware. Also on February 23rd, our next that ID series will have a special guest, Dr. Rob Akins from Nemours, and he'll be speaking on team building and translational science, chemistry, biomaterials, and improving recovery after vascular surgery. So please register for both of those events to help us prepare. Then also the full schedule is posted on the DE-CTR.org website. Lastly, registration is still open for the upcoming ACCEL Community Research Exchange Conference, and that'll occur on March 12th. The keynote speaker for that event is Dr. Georgia Dunstan, who is the founding director of the National Human Genome Center based out of Howard University. She's an accomplished speaker on health disparities in genomic research. So with that, it's my sincere pleasure to introduce our speaker today, Dr. Matthew Hoffman. Dr. Hoffman joined Christiana Care in 1995 and currently serves as the Marie E. Pinizotto, MD, Endowed Chair of Obstetrics and Gynecology. He also serves on a number of committees, both nationally and for Christiana Care, including serving as an advisor for the Joint Commission on Obstetrical Issues and a national measure steward for quality markers in obstetrics. In addition, he holds a gubernatorial appointment on the Delaware Domestic Violence Coordinating Council. As Director of Obstetrical and Gynecological Research at Christiana, Dr. Hoffman has conducted studies and led initiatives that have contributed to reducing the infant mortality rate in Delaware and reduce the use of unnecessary medical procedures during childbirth. He's also a funded researcher doing work both nationally and internationally on behalf of the National Institute of Child Health and Human Development's Maternal Fetal Medicine Units Network and their global network, among others. Dr. Hoffman is also a fellow of the American College of Obstetrics and Gynecology. He frequently lectures on women's health issues, including domestic violence, pediatric gynecology, menopause, and obstetrical emergencies. He's also a reviewer for several medical journals in his field, including Obstetrics and Gynecology and the American Journal of Obstetrics and Gynecology. Dr. Hoffman earned his medical degree in 1991 from the University of Florida College of Medicine. He completed his residency in obstetrics and gynecology at Pennsylvania State University in 1995. And in 1998, he earned his master's degree in public health with a subspecialization in maternal child health research from Johns Hopkins Bloomberg School of Public Health. Please join me in welcoming Dr. Hoffman.
divide by 2, that's actually how many children or pups that they're supposed to have. And that seems to hold true across the animal world. Likewise, we know if you're a rat, I know exactly how to cure your preterm birth. So all other mammals drop their progesterone level immediately before they drop. Turns out humans probably have what's called a functional withdrawal of progesterone, meaning they make normal levels of progesterone, but a second hormone called estriol seems to go up. And it turns out that babies probably control the majority of estriol. So the idea that actually a baby plays an important role about whether or not they're going to be born is something that we've known for many years, and partly to guide some of the strategies that we're looking at. The other point just to make, and I'll talk a little bit about this, is the placenta, and it just was Valentine's Day, so I thought this picture was appropriate. If you think about it, historically, we haven't thought much about the placenta other than to throw it in the trash. But if you think about it, it really is the interface between the mother and the baby. And in fact, if you look at most of our poor outcomes, they're really a failure of the placenta. So whether you're talking about preterm birth, preeclampsia, growth restriction, or stillbirth, the placenta is a key organ in the middle and something which we've only recently begun to think more about. So if term birth is normally 40 weeks, what happens and why do things go wrong? So this is a complex slide, and I want you to ignore everything else but except the top line. So there really are probably 4 ways that the placenta and or baby signals that they need to come out early. So the first one is what we call the activation of the maternal fetal HPA axis. So again, we know that if we actually take out the baby's adrenal, that baby is never born. So this has been done with other creatures. And in fact, the adrenal is a huge part of what happens. And in fact, our adrenals are largest right before we're born, and then they actually shrink down. And they actually play an important role in stress. So the baby being stressed is one signal. So babies who have placental problems, not getting enough blood, undergrown, probably work through this pathway. The biggest pathway is probably actually inflammation. So the idea that inflammation is really the mother trying to say this is such a hard environment that the baby needs to be born plays a key role. This is inflammation and infection, and again, they're related but not identical concepts. The smaller percentage is probably from the placenta separating, or something which we call abruption or decidual hemorrhage. So we know that women who have bleeding in the first or second trimester are significantly more at risk for delivering early. And then finally, what I'm calling pathological uterine distensions, but this is basically twins, triplets, other diagnosis, or congenital problems with the uterus that these babies are born to be more soon. There's a general rule of thumb in obstetrics: for every child that you add, you take away 4 weeks of that gestational age. So if you have twins, they're typically born at 36 weeks, triplets are born at 32, and so on. So again, the idea that the uterus can only grow and accommodate so much is the 4th predominant pathway that exists. So how are we doing? So it's probably important to kind of look at where we are compared to other countries and how the temporal changes have occurred in the US. So just real quickly, if you look at preterm birth in terms of its immediate impact, preterm birth represents about 3/4 of the deaths that occur around the world. If you look at the cost of a preterm birth compared to a term cost, and this is data from 2006, it's about 12 times the cost of a term birth. And if you look at the cost of a preterm baby, it's about $54,000 in 2006 versus about $5,000 for a term baby. Again, these numbers have gone up significantly, and a total cost of about $26.2 billion. But that's not the whole story about preterm birth. So prematurity touches this child in every way. So it doesn't matter whether you look at the baby's brain, the baby's kidneys, the baby's height, the baby's weight. Babies who are born early are different than babies who are born at term. So this is just a little graph looking at gestational age, and this is looking at IQ. So if you look at an IQ, your IQ is actually highest amongst babies who are born at 40 weeks. Interestingly enough, the IQ starts to drop after that, and babies who are born even early as what we would still call term have lower IQs, and you can extrapolate this line out. So again, we know that brain development is affected. If you look at the kidney, if babies who are born preterm have about 30% less nephrons, or the active unit of the kidney works with, than babies who are born at term, and this is looking babies at 34 weeks. We know that if you are born preterm, you're more likely to develop high blood pressure, kidney problems, need a kidney transplant. So it's not just simply surviving the episode of prematurity, but this whole idea of life course. In fact, these babies that are born preterm are higher risk for heart attacks as well. And again, preterm children are shorter, have smaller head circumference, and lighter than looking at their term period peers. So although we talk about great successes with what's happened in preterm birth, the reality is that this really bears throughout the life course of the child. So this is just to kind of give you an idea what the global perspective is. So just to kind of keep it simple, dark blue is bad. Light blue or white is good. If you look at the United States, we fare comparably to India, Malawi, other countries. Again, this is a problem that's across the world. Last year in 2012, there were about 15 million children who were born premature. About 1 million of them died of that. Most of them occurred actually in Southeast Asia, with India, because of their large birth numbers, leading the charge. In terms of the US, we have had some good stories. This is through 2014 data. I will tell you that actually we're up to 2015 data. Unfortunately, this downward trend starts to go up the opposite direction. But what you can see is from 2007, both amongst Blacks, who clearly have a much higher rate, as well as Hispanics and non-Hispanic whites, you have seen some decrease in the preterm birth rate, although not in any way startling. So this is kind of a representation. So Cynthia Giampi, who is at Columbia and Condia Num, looked at birth certificate data from 2005 to 2012. And what you see is a good news story. So preterm birth decreased by about 15%. And again, the part that we control, meaning the obstetrician chose to deliver that baby, declined by about 17%. And the good news is that it was across all of the gestational ages. So whether you were really early, 24 to 31 weeks, 32 to 34 weeks, or between 34 to 36 weeks, there was a significant increase or decrease in the rate of preterm birth. Although we'd like to take credit for it, we don't deserve it. So there was about 100,000 decrease in the number of preterm birth. Karina Schoen and Vince Bergella and some other folks from Jefferson looked at why. And in fact, a lot of the reason was not that we improved care, but things happened within our community. So our two highest groups of folks who are likely to have preterm birth, teen moms and older moms, in fact, their numbers fell significantly. So less folks under the age of 20 were getting pregnant. And again, many of our older patients who often have higher preterm birth rates, those rates just declined because of changes that have happened within our communities. Likewise, higher order multiple gestations, meaning twins and triplets, et cetera, have declined, in large part because of our IVF friends, rather than putting in 2, 3, or 4 eggs back in, are now by law actually putting in 1 or 2. And even if you look at the simple issue of decreasing smoking bans, simply creating rules around indoor air pollution have probably contributed significantly. From the interventions that we have medically, we can only claim about a quarter of the preterm birth is actually due to changes that we've made in care from that perspective. So if we're going to change the rate of preterm birth, we really need two things. One of which is we need to be able to identify the women accurately, and then we need to be able to treat it effectively. So if you think about it, we need to be able to screen, and we need to be able to treat. For the next couple of slides, I'll talk about some of the screening strategies that we've been involved with. So since we're close to Philadelphia, this is my favorite John Wanamaker quote: "Half the money I spend on advertising is wasted. The trouble is I don't know which half." So a lot of what we do is we think effective, but we need to make sure that it is. So what about just simply asking a patient whether or not they're at risk? So we know that women who have had a prior preterm birth, that they in fact are at markedly increased risk for a subsequent preterm birth. In fact, almost 4 times. This number goes up if you've had multiple preterm births, and particularly if you've had a baby early. So if you've had a baby at 28 weeks, you're much more likely to have a preterm birth. Again, if you had a baby at 36 weeks, and your most recent birth is predictive. Interestingly enough, there also seems to be a racial differences with African Americans who've had a prior preterm birth are much more likely than Caucasians to have a subsequent preterm birth. There's been a lot of folks trying to dissect this out, and there are a lot of things that play into this. So people are looking at what is your zip code or geolocation, looking at your family history. If the pregnancy was fathered by a baby who was a preterm, that baby pregnancy is more likely to be preterm. If you look at maternal age, stress, depression, low SES, low educational attainment, they all seem to play a role. So again, looking at traditional models, how good are we predicting preterm birth? Well, pretty bad. So insensitivity, meaning if we identify somebody, are they likely to deliver preterm? We get about 1 in 4 preterm births. And again, with the positive predictive value, meaning is that woman likely, is very low from that perspective. Again, people are looking at other models to do this using computers and something called logistic regression. But again, those still are yet to be untried. So what about looking at biological markers? So this is one that's been out in the literature for about 20 years. It's called fetal fibronectin. So this is a test that many of you may be familiar with. So fetal fibronectin is actually an anchor protein between the membranes of the pregnancy and the lining of the uterus. And actually was developed as a test for rupture of the membranes. And then they noticed, gee, it seemed to predict preterm birth. So the challenge is, although it has great utility in terms of mothers who come in with contractions telling if they're likely to deliver preterm birth, as a screening test, it's terrible. So we did a study of 10,000 women. This appeared in JAMA of last year. And if you have a perfect test, it has a 1. If you have a terrible test, it has a test value of 0.5. So this is looking at all the cutoffs. If you notice, none of these are 1 or even close to 1. So again, the idea of screening people just asymptomatically without symptoms, it's a terrible test to say the least. So again, probably not well advised. A little earlier, I touched at the adrenal gland, and this is actually a picture of what your adrenal gland looks like in utero. And this whole thing is the adrenal gland. And if you see this whole white area, this is called the fetal zone. And this immediately disappears immediately after birth. So in fact, your adrenal gland is biggest right before you're born compared to the rest of your body size. And going back to the 60s and 50s, when they looked at babies who died of preterm birth, the spontaneous preterm birth, they noticed that their adrenal glands were comparatively large to other babies of the same gestational age. So what we think is happening is that this gland is secreting stress steroids, and those are converted to that estriol. So if you remember me talking about, we have progesterone, and then estriol in humans seems to go up comparatively. And the question came up of, can we actually just do ultrasounds to measure this? So Azan Turan from the University of Maryland looked at this. And he looked at people, again, who came in with symptoms, and he looked at 74 of them. And in fact, what he found is that this was a pretty good test if you came in with symptoms. So he found that he picked up 100% of the people, and in fact had relatively good specificity from that standpoint. So again, early on, it seemed to be a good test looking at a small number of patients. So I foolishly took this up, and we looked at 1,700 women almost. And again, going back to that idea of 0.5 being a lousy test, it's a lousy test. So again, we were not able to find any signal that looking at adrenal gland, particularly further up earlier in pregnancy, had any benefit. And the benefit may be relatively relegated to mothers who come in with symptoms or are near their preterm birth event. The other thing which was kind of interesting that came out in the 90s is looking at the cervix. So it turns out that the cervix opens from above long before people present with preterm. So this was a study that was published in the New England Journal looking at the MFMU group, and they looked at about 3,000 women. And what they did is they measured the length of the cervix using ultrasound. Normally, this part of the cervix here should be closed. And if you look at it, this is what's left. So not surprisingly, the cervix opens from the inside out, and we can't really get to the inside unless we do ultrasound. And what they noted is that the shorter the cervix got, the more likely you were to deliver preterm. So if you had a cervical length of about 25 or more, you were likely to deliver at about a 7% rate, versus if you looked at preterm moms, they were much more likely to have a short cervix. So though it's really good if you find it and we can treat it, the problem is it worth screening every woman? So this comes out of that same study that I mentioned, where we looked at a little over 10,000 first-time moms and we did cervical lengths on all of them. And again, this idea of a perfect test being 1 and this being a poor test at 0.5, you can see all of these numbers say it's a relatively bad test. So only about 10% of preterm births will actually go through a short cervix as their pathway. So going back to the idea of looking at other markers from the placenta. So one of the things is we know is the placenta secretes proteins. So can we look at proteins to see if we can pick up a protein signature? So again, birth is a process. The mother talks to the baby. So this is a study that we participated in and looked at about 5,500 women to see if we could predict preterm birth. And what you want to do is have differences in protein expression for moms who are likely to have preterm birth compared to term birth. So again, what we did is we looked at a series of proteins and we did it in 3 different groups of women. But what you can see is that there's overexpression of certain proteins and underexpression of proteins. And the ideal match would be to have overexpression of one and an underexpression of another, and to develop a test. So this is the test. This is now commercially licensed. It's called the Preterm test. Again, it's by a company called Sera that we're working with. And they actually identified 2 hormones between 19 and 22 weeks that seems to be highly specific and highly sensitive for preterm birth. So they looked at sex hormone binding globulin. Sex hormone binding globulin is kind of a friend of progesterone, something which we've talked about. And then they identified a second protein called IBP4, and that seems to reflect the health of the placenta. So putting them 2 together gave us relatively good values. Again, a perfect test is 1, and an imperfect test is 0.5. So looking at preterm, meaning 37 weeks, it picked up about 3/4 of them, if you will. What was really fascinating, if you looked at the really early kids, the under 35, it got a rate of 0.93. So in terms of all the tests that are out there, this seems to be the most predictive from that perspective. So again, this is commercially available. You get a report, it comes out, it actually tells you what your risk of having a preterm birth is. They actually have the ability to tell you what week your baby's going to be born in within a week window, 95% of the time from that perspective. And then they also are able to tell you what your increased risk is above the baseline from that perspective. Just real quickly, another area that one of the research groups that we're involved with is starting to look at exosomes. So again, not just looking at proteins, but there are these little vacuoles that all of our cells make and release. They're sort of little trash cans of proteins. And there's a lot of interest in this, and there's some evolving literature as it relates to exosomes. So we've talked a little bit about spontaneous preterm birth. What about birth caused by preterm birth? By doctors for very good reasons, but there are lots of opportunities. So this is comes from Pogo, 1970. John, remember this? You're my reference for age, John, in the audience. Sorry. So this was about pollution, which is obviously endemic in the 70s. And we said we have met the enemy and he is us. So Cynthia Giampi and I looked at both our own internal population as well as Columbia, and we looked at the births that occurred between 34 and 37 weeks. And again, this was back in the 2000s. We found out that about half the time, although there were good reasons, they were not solidly evidence-based, meaning doctors were often taking a series of bad reasons to put them together and cited the opportunity to improve upon some of the guidance, and that has now come from that perspective. So again, the idea of making sure that we have good guidance and for physicians, and that's been partly the decline that I showed you early. The other idea is not just simply treating the baby. So again, we tend to deliver babies for our purposes for either they're small, too small that we're worried that the baby's going to pass in utero or result in a stillbirth, or preeclampsia, a common condition that affects about 7% of our first-time moms, where they have high blood pressure. And in fact, we're the only creature on the planet that does this. So preeclampsia is very unique to humans. It may be adaptive, and again, tends to be higher in certain groups. So again, there's this now kind of renewed focus on, rather than just treating and delivering the baby when it gets into trouble, can we prevent it? So here's an example of two placentas, and again, the idea of placental health. This is a healthy placenta. This is not a healthy placenta. We could go through all the microscopic changes, but I think you only need your own eyes to recognize that they are two very different placentas. This is white in part because all of the vessels are calcified and there's not enough blood flow to the placenta. So what about aspirin? So again, aspirin probably promotes blood flow to the placenta, prevents clots from going to the placenta, and in fact may help the placenta to grow healthier. And if you put a piece of placenta and you put it in a dish and try to grow it and you add aspirin, that placenta will grow more robustly than if it doesn't. So particularly if you look at early initiation of preeclampsia, meaning under 6, or an early initiation of aspirin under 16 weeks, there's about a 50% reduction of preeclampsia, severe preeclampsia, growth restriction, and interestingly enough, preterm birth. So again, this whole idea that the placenta is the mediator and inflammation is an important opportunity to look at. Taking it one step further, many of you may be familiar with the drug called pravastatin. It's a cholesterol drug. It does lower your cholesterol. It was some interesting work done about 5 years ago where they looked at how much do they impact upon heart attacks do they see is due to pravastatin, due to cholesterol, but how much is it due to other things? So only about 1 in 4 decreased heart attacks could be explained by the changes in cholesterol from that standpoint. In fact, increasingly, people begin to think of it as rather than a cholesterol drug, but as an anti-inflammation drug. So this was a study that was done through the Columbia group, not here, where they looked at 20 women who had had a history of preeclampsia very early in their pregnancy, before 34 weeks. And half of them got pravastatin, half of them got placebo. In the women who got the pravastatin, none of them got preeclampsia, versus 40% got preeclampsia in the other group. This same result is going to come out in an abstract next month, looking at a slightly higher dose, and they see exactly the same finding from that standpoint. If you look at the blood markers for preeclampsia, and I won't go through them, and everybody who got pravastatin, they were normal, and everybody in placebo, they were abnormal. So we know what causes preeclampsia, and it's related to these blood markers, but it seemed to normalizes it. Cholesterol was the same between the two groups, and in fact, if you look at the cord bloods, it interestingly enough seems to only be on the mom side. You can't find traces of the drug at this level on the baby side. So there are a number of groups internationally who are looking at pravastatin from that perspective. Moving on, this is a trial that we're replicating in the US called the TOPS trial that I referenced earlier. This is again the idea of rather than worrying about all these biochemicals, can we simply just close the cervix shut? Can we put a little plastic donut called a pessary around it? And the idea is to close it and like a balloon sort of twist it a little bit so that we can keep the cervix shut from that standpoint. So the Spanish did this and published it in the Lancet in 2013. They looked at 385 women in 5 hospitals. These are women whose cervixes had already started to open up using that ultrasound finding that we showed before. And they looked at women whose cervixes had shorted less than 25. And what they saw was about an 80% decrease in preterm birth before 34 weeks. And there was about an 80% decrease in delivery before 80 weeks. And they only had one patient who withdrew from the study across all of theirs. The challenge is this finding doesn't seem to be consistent. So another group did almost the exact same trial. And in fact, in their trial, they saw no difference. So they're actually are now multiple trials going on, including the US trial, which will get 850 women to look at this pessary device. My slides are out of order. So going back to aspirin, again, we're helping with a large trial of almost 12,000 women to see if we can prevent preterm birth and prevent inflammation by giving folks aspirin. So again, overall, prematurity, if you look at all women who get aspirin, it's about a 20% reduction. This is one meta-analysis. The USPTF in 2014 said about a 15%. But if again, you look at women who have it early, there's about a 60% decrease in preterm birth. And the question is, should all women be on a baby aspirin from that perspective? So again, this is a single trial which looked at it, and again, starting early, they saw about a 50% decrease in preterm birth. And again, there was another paper that showed about a 50% decrease. So although we're using aspirin more liberally for women who are at risk for preeclampsia, the question is, should all women be receiving a baby aspirin? And again, that's part of the trial that we're conducting internationally from that perspective. So that's a little bit about where babies come from, what happens to babies who are born prematurely, ways that we're trying to figure out who is born prematurely, and then what we're trying to do about it, whether it's a pessary, aspirin, pravastatin. I sort of skipped over progesterone because I think it's pretty well known at this time from that perspective. So I'm happy to answer any questions. And it left out my Bill Gates thing. What questions can I answer?
For the aspirin, is there any concern about ductal closure and
No, so a couple points. A, there is consistent data. There's no ductal closure. There's been over 45,000 women who've been in aspirin trials, so this will be the largest trial. What is interesting is neurological follow-up. So the one large British trial, they followed kids not perfectly. There were no differences in those kids related by their parents or their pediatrician. There was a French study where they followed up just the preterm kids, and the preterm kids at age 5 had lower rates of lower IQs, they had less behavioral problems. If you looked across the developmental spectrum, did better. So neurological development is also an inflammatory mediated issue, as well as a nutritional issue. It's a whole bunch of different things. But interestingly enough, at least the early literature see that it's beneficial. The challenge is that there was a recent paper that came out that said there was a slight increase in CP in kids who were exposed to aspirin. But the response was much clearer actually with Tylenol. And I don't think I've met a woman who is pregnant who hasn't taken Tylenol. So the data was much better about Tylenol and actually reasonably consistent. But the aspirin data is sort of missing. We're talking about developing a follow-up study. We've already written the protocol for our aspirin cohort to look at developmental issues.
Just a follow-up question with that. Was it corrected for the neurodevelopmental outcome? Was it corrected for the prematurity? So like the aspirin group, regardless of whether they were premature or not?
So the French study looked selectively just at preterm kids, where they showed the benefit, and because they had longitudinal follow-up select their version of child watch, late child watch in French. So they had follow-up for all of those kids. They were able to go back and look at that data. Was not blinded, and the follow-up was about 75%. Children in that group. It's interesting. No.
now? What's the mom during early pregnancy test positive for zero test high risk for birth? What's the subsequent follow-up treatment pathway from there? You know, once you show a high risk.
Yeah. So couldn't play it. Yeah. So there is we'll be starting to screen women routinely. We're finishing In women who are found to be 2.5 times the risk of general population, will be offered progesterone, which has been around for many years, and then treatment with aspirin. Following up adverse events within those groups as well, but they're pretty benign, pretty well accepted intervention globally.
The aspirin data was just for preeclampsia. So general. So even though, is that SERA encompassing of preeclampsia enhancement? Or just...
Yeah, so there's unpublished data that I think enough. The test also picks up about has an AUC of 0.74 for preeclampsia. It probably speaks to this whole idea of placental. So if you have preeclampsia, you're not only at increased risk for preeclampsia, you're more at risk for spontaneous preterm birth, growth restriction. Turns out it doesn't matter which lens you look through it, all of those things flow back and forth. So there are different pathways of these problems.
With regard to the SERA product, could you just clarify, you said it's available commercially. Who is getting it right now? Who has access to it?
So again, we're doing it as a research study because I don't think it's responsible for this. The quote I was going to play, Bill Gates actually talked about this at the recent JP Morgan issue. So Gates has put in $35 million to develop this for the developing world. So it's not commercially available. I don't think it's appropriate to do anything except in a research environment. And the challenge is this is really the Titanic issue. So the Titanic, they saw the iceberg, but can you turn the ship? And I don't know the answer to that question, and that's why we're doing this study. So we'll be offering women at 19 to 21 weeks to get tested. Those who choose to get tested will then be offered progesterone and aspirin to see if we can make a difference.
Is there alternative medication to moms who are allergic to aspirin?
No, the challenge is, again, we have this huge safety data about aspirin. So again, there are 45,000 women that are longitudinal follow-up studies. Aspirin, if you look at the USPTF recommendation, says basically you have two risk factors: African American, first-time mom, obese. Above the age of 35, under the age of 20, could be on aspirin. There are a few more. So again, aspirin liberalization has been liberalized in this country. Probably we don't have an alternative.
The two Spanish studies you spoke about the PESERA, do you know if they stratified or looked at the differences for in either of the studies?
So they did. Again, they saw effect across the board. So the difference between the Spanish and what I call the English study, the English study, 1 in 4 women took their PESERA. And the other part is no one was trained in how to do the PESERA. So we've actually had the daughter of the inventor train all of our providers. She showed up with a puppy. Different person. Other questions?
Any infection rates with the PESERA? I thought there was like a few years ago there was concern about increased infection for you with.
So no. So so there doesn't seem to be. Again, there is a tremendous difference in vaginal discharge, just like you would have any foreign object in the mucosal surface cause it. One of the theories in the Ohio State group is looking at this is they think the PESERA doesn't work because it seals the cervix shut. They think it's bacteria and that's what's protected. We're actually taking swabs of women post-PESERA to see how all of the bacteria change. Are we actually promoting healthier bacteria? Nothing to do with the fact that it's closing it up. It's a fascinating idea. I have no idea if it's true. So again, we know that infection from the vagina going through the cervix is related to rupture of the membranes in preterm birth. So again, the question of is it a difference? Thank you for letting me share my hobbies.
Thank you.